Thank you for giving me the opportunity for this lecture for journey and treatment of anterior instability, then, now, the future. This is a great honor to be here with you without, unfortunately, a face-to-face meeting, but I hope it will happen again, and I wish all of you a very safe meeting here. So the dislocation and reduction early began in 12th century before Christ, and this is the Egyptian description of dislocation. And then we have Hippocrates, who was so important to show the first technique of reduction of the dislocation. We go to the 19th century now, after Jesus Christ, to see the fundamental concept of solar instability. And here we know about the famous Malgane and the Broca and Hartmann 1980. The soft tissue stabilization started to be described in 20th century with the famous Peth and Putty-Platt, the Bankart, and all these surgeries were so important. And even on the same time, we developed the treatment of bone defect with Eden and Ibinet and the famous Tria and Latarget, French guys, and Bristow from England, Connolly, Sar, and Weber for the osteotomies. And at least now we come to 1980s, where we started to have the very famous arthrogram, followed by the arthroscopy, and of course the very important arthroscopy that started on that time. Arthroscopy was really led by US, with Rick Gaspari in 1984, who was not only a surgeon, as you can see, with the findings in subluxating shoulder and the arthroscopic anterior shoulder capsulography, described the technique, as well as Lenny Johnson and Eugene Wolf, who started to develop the first shoulder stabilization with anchors. Arthroscopy was the identification in 1993 of the outside, the glad, the Hagel lesion, and all this description that were done on the period so interestingly by this surgeon. The technique of arthroscopy were very successful at the very beginning, but here came the French team, and in the 1993, 95, and then we had Daniel Mollet and Henri Coudin with the French Arthroscopic Society, who started to show that they have a lot of recurrences after Bankart, arthroscopic Bankart repair of this technique. So they asked us to develop, the French Arthroscopic Society and Pascal Boileau, prospective multicentric study where we isolated that the Bankart lesion was something, the Bankart with Hagel lesion and even the IGSL distension were something that were very common in shoulder instability. So it was not only the Bankart repair that could repair this lesion, and we defined in 2000 arthroscopic type 1, type 2, type 3, where the type 3 were not maybe the best option for basic shoulder stabilization arthroscopically with the Bankart repair. That was even supported by the fact that the bony lesion was not something treated with arthroscopic technique, and the inverted Pierre glenoid and critical bone loss, which Jolibier and Burkett was described, which is a very important thing. And here came a team in US of arthroscopic surgeons who started to have some doubt about the arthroscopic technique, which is a universal technique for repair. The 3D CT scan came in, and the description inverted Pierre glenoid was even more developed with the perfect visualization with Matt Provencher, and N.G. Toy with Di Giacomo Giovanni developed the bipolar defect with the on-track and off-track classic lesion in this 2014 period. Now, what about the Latarget procedure? Latarget was a guy from Lyon from 1954, a French guy who was just a friend of Tria, and he developed this cricoid transfer for stabilization. Didier Pat in 1983 developed the triple transfer, and Gilles Valch in 20 developed the fact that it did the split instead of the detachment of the upper part of the subscap. The Latarjet procedure is to expose and to prepare the coracoid, to split the subscap in two parts, and to fix the coracoid at the anterior glenoid border. Arthroscopic Latarjet procedure came in, and that was Gilles Welch really introduced the concept in 2000 when he told me on this podium, I will do arthroscopic stabilization when it will be possible to do the Latarjet procedure arthroscopically. So I worked on it. And we developed the arthroscopic bone stabilization that we published in 2007 with this concept. And this arthroscopic Latarjet is, as you know, something which is used with the different ports and 7 ports outside. And these are different position and different steps. But this video is quite interesting because we can see here that the indication is the engaging heel sacs lesion. But one of the most important things for this indication here is that there is no Bankart problem. There is no labrum detachment. The fact is that this surgery is needed for this patient, not because there is a ligament detachment, but a ligament tear. And this ligament tear is certainly one of the most important indications, as well as what the failures of arthroscopic Bankart are for arthroscopic Latarjet. So, you know, the following step is the detachment of the pec minor, and then we go to the preparation of the coracoid process, which is right here on that position. And here we go to this coracoid process preparation in order to drill and to prepare the holes, followed by the osteotomy in order to have a nice visualization of the coracoid process. And then we go to the split of the subscap. The split of the subscap is something that is quite one of the most difficult steps of the surgery. Why? It's because of the proximity of the axillary nerve. This is the coracoid process, which has been cut. And here is the location of the axillary nerve. As you can see, it's very close, and it's really on the area of where we should perform the split of the subscap. And here you perfectly see that the axillary nerve is at the inferior border of the subscap. That is just a union between the upper 2/3 and the lower third. There is always a little vessel on that location. And here you can see that we go through the muscle. It's very important to manage the split at the level of the muscle, mostly, and not so much at the level of the tendon, because on the back of the tendon, you have the humeral head, as you can see here. And on the back of the muscle, what we will see here is the glenoid. So the window will be open on a while, and you will see that here we will have a much better visualization of the glenoid as well as soon as we have opened this window. And here we can show the glenoid which has been prepared before. The next step is to prepare the holes, and then we go to the fixation of the coracoid process, which has been prepared here. And we will see that the coracoid process is inserted inside the shoulder with this articular once it has been prepared by the burr. So this is the coracoid process, which is inserted right here on this level. And here we see that we prepared a little tube on that location just to be sure that we're in a good position. And then we will have the 2 screws inserted in this coracoid process here was the problem. So what is about now the arthroscopic Latarjet procedure? What are we talking about? And we defined it in 2007, but Pascal Boileau developed a technique even differently with the belt and suspender technique with this. And then we had a lot of people following these techniques and developing like bone graft and like allograft, like tibial allograft, or like different variation and different variation for fixation with not only screws, but sometimes underbutton or cerclage, whatever. So a lot of technique has been pushed. The question is today, what about the advantage of arthroscopy versus open? And a lot of studies has been developed here on that moment. And it looks that honestly, arthroscopy today doesn't bring more advantage than open, maybe cosmetic, but it's a real, it's a reality that today we move forward and we do more and more arthroscopy instead of the open treatment for every pathology in the world. So for the shoulder, it should be the same. What about the complication? The complication and the techniques are quite different. But one of the most important complication is the recurrence. And at that time, it shows that the Latarjet has less recurrence than the Bankart, arthroscopic Bankart repair for some authors, and for some others, it's not true. So the case is still here, the debate is still open, and discussion is here, and we still need to improve, to check the results, and to see what happens. So the results and complications, the soft tissue procedure, arthroscopic and open Bankart is faster, less aggressive, is easier, doesn't treat the bone defects, and has more recurrences. The bone block procedure, open versus Latarjet, and Latarjet, and treat an arthroscopic Latarjet treats bone block defect. It's a Latarjet supply ligament insufficiency, and it brings less recurrence, but it's much more difficult. It brings some possible serious complication, and the revision of this technique may be very difficult. So what about the future? Prediction, what to do. Predictive factors, Bankart versus Latarjet is certainly one of the key for the future. Determining exactly what kind of surgery we should do and what are the key parameters to decide has been developed by Pascal Boileau for the EASY score. And you know this EASY score that shows that with that score, if it's under a certain value and then or above a certain value, I mean the soft tissue should be indicated or not. And it's not the only one. The parameters about the bone and the inverted pier is something very important. And the redefining the critical bone loss in shoulder instability is something which is under study today, and we try hardly to perform as something interesting. So what about now the ligament? The inferior glenohumeral ligament is the key to be repaired in the shoulder anterior stability. And we definitely in the future need to better assess this ligament. We better assess this ligament with clinical sign, and we develop with Thibault, my son and partner, the hyperextensional internal rotation test, which is the HARI test, which is the test that we make in stretching and internal rotation with the posterior stretching here. And we found with cadavers and cadaver studies that it's a very reliable sign that does not create any feeling of instability in more than 95% of the cases. And it's a very reliable test that shows the stretching and the damage of the inferior glenohumeral ligament, which is maybe something important. But we need to have a better assessment of this. And we need to have maybe a better and stronger repair. This is why the material has been changed, the anchors has been changed, the sutures has been changed, and the material has been improved. The technique has been differently presented with a double row technique of the repair of the ligament area in order to have a better healing here. And now we should develop a better assessment of the bone block and of the bone loss and of the bone quality with imaging technology, with better MRIs, with CT scans, and with others that may come in the future that will tell us exactly what is the shape of the image with the 3D printing of the shoulder that will help us a lot to understand where we should put or not put a bone graft or should we manage just to do some soft tissue repair and some ligamentoplasty, maybe without any bony supply, like it has been developed more recently? Improving the ligament of assessment of the ligament is certainly one of the most important things to develop in the future. Because today we don't know how to assess the quality of the IGSL before surgery. What about its thickness? What about its elasticity? What about the vascularization of this ligament? What about the potential of healing of this ligament? And what about the innervation of this capsule that may inform a lot the shoulder and the brain of the patient after surgery? So we should certainly improve the technique of arthroscopic technique, like it has been done for the Bankart repair, with the famous surgeon today who are showing with stitching everything easier to make it easier, and even for improving the technique of arthroscopic Latarjet. Arthroscopic Latarjet is a very difficult surgery today. Should be easier, should be faster, should be safer. It should be more reproducible, and it should allow to have an ideal positioning every time. Of course, today I have more than 800 cases experience, and it's still a difficult surgery, even if we do it very often with good results. So what tool should we get in the future? The 3D pre-op printing, maybe the 3D arthroscopy, in order to understand better what we do and where we place the bone block. The 3D virtual surgery, in order to have something that will show us exactly where we are and how we place according to the little window that we have during the arthroscopy compared to the big bone that we have to manage. And then the robotic assistance. Robotic assistance is certainly one of the keys to place the bone graft, even if it's bleeding, even if you don't know, like IFR piloting, when you go and when you don't see so well in the clouds and you want to land. But of course, at the very end, you need to see. And I think that we still need to have in the future good surgeons who are working. So what about evolution? Evolution for sure is something important. And we evaluated for many, many things. We evaluated for transportation here, as you can see. And we evaluated for many transportation, but with injuries everywhere, for the new technique, for the old technique. And the evolution, of course, is here in every steps. And unfortunately, we have complications everywhere, but we still see the sunset, the sunrise, and we'll still perform due to the wonderful partnership with the technology, the improvement and the performance in the future. So we will certainly improve the surgery and manage to do the surgery in wonderful technique with always that you show in your country, always technique, and look at this wonderful possible artificial hand that is working here, that shows the technology that which is here for the medicine and the future. What is the secret for the future? The knowledge of anatomy. Nothing will replace the need anatomy. Improve technology, but all these parameters are nothing without education. And the fellowship is certainly very important, but the most important parameter that is fundamental for succeed is work. And thanks to JP Warner to make me discover this wonderful outlier book, The Story of Success from Malcolm Gladwell. 10,000 hours is a minimum. So the future will happen, but only if you work, and work. So, guys, ladies and gentlemen, I hope to see you soon, to have maybe the third generation that will see the future. And I hopefully see you in Annecy, October 14, 16, 2021, face-to-face meeting for the real life surgery. Thank you so much, guys, and enjoy your meeting. Bye-bye.